Hello everyone. Today we are going to see about the structure and the function of the umbilical cord. As what we know that we have seen about the function of placenta, that is, it is the transport. What is transport? It transports to whatever the nutrients from the mother to the fetus, and whatever the waste products are removed from the fetus to the mother via umbilical cord. So first of all, what we should know is what is the structure and function of the umbilical cord. So first, what we are going to see is how is the umbilical cord. Umbilical cord is covered by amnion, and what it contains. Content-wise, it is initially contains the two arteries and two veins, and afterwards it contains a single vein, single umbilical vein, and two umbilical arteries which are supported in water jelly. And as we know that umbilical vein carries the normally any vein carries the deoxygenated blood, except two, that is the umbilical vein and the pulmonary vein, which carries the oxygenated blood. And the umbilical arteries, as we know that arteries carries the oxygenated blood, except that is the umbilical arteries and the pulmonary arteries, which carries the deoxygenated blood. And all these things which are covered by the water jelly. Amnion covers the umbilical cord except near the fetal insertion, where an epithelial covering is substituted. The arteries wind around the umbilical vein in a spiral fashion to stabilize. And because the vessels are longer the cord itself, there are a number of foldages, or what we say that the it looks like the torsions like and producing a protrusion, or sometimes it may look like that of a false knots on the cord surface. Uh, then the water jelly, whatever the outside covering which is there, what is its function? So what it does, it protects the vessels from the undue torsion and the compression. That is which can it lead to. So these that is the basic one. What we are going to see. So now we are going to continue about what is the basic morphology of the umbilical cord. If we say that it is the connection between the placenta and the fetus, and the next important it is what is the length of it, what is the diameter, what is the shape, and what are the contents of it, and where it is attached, and what is its function. That what we are going to say it. So if we see the lengthwise, it is about some 50 to 60 centimeters. If why we are always saying is saying normal things, because if anything abnormality in the length can lead to the problem. That is, if the length is short, there is also a problem. If length is long, there is also a problem. Then diameter wise, it is about some 2 centimeters. Then shape wise, if you see the umbilical cord, it is the torches, and it's showing some false nodes also. And the content wise, as we know that initially there are two umbilical arteries and the two umbilical veins, but afterwards there are two umbilical arteries and the one umbilical vein embedded in bottom cell, which will definitely protect it and protects it, and it is surrounded by amniotic membrane. Then next point, where this umbilical cord it is present. So from the attachment point of view, it is attached to fetal surface of the placenta. We know that placenta is having two surfaces. That is one that is towards the mother, that is maternal surface, and the inside that is related with the fetus, that is fetal surface. So definitely, but obvious, it is going to be on the fetal surface of the placenta. That is, and where it is present on the placenta at the center. So that is the normal one. And the other attachment, but obvious to the mother, that is related with that of the fetal abdominal wall. That is we are going to see it. Then functions. So what is it? It contains the umbilical vessels that connect the fetus to the placenta, and whatever the transport which is we say the function of placenta, this transport from placenta to the fetus is done via umbilical cord. That is the function of it. So if you are going to see this diagram, how it is, what I have already explained, that is, it is this, which one is this surface? This is the whatever it is the, this one is the fetal surface. And from center, that from the center, this umbilical cord, how it is a twisted structure, a round one, twisted structure. Whatever this shiny part, what we are seeing, it is the water jelly and the amniotic membrane which is present. And this inside of it contains two umbilical arteries and one umbilical vein. Umbilical vessels radiated to form chorionic vessels, and this one it is related with the amnion, which is transparent. The chorionic vessels that is under the amnion, that is how the practically or the actual how the umbilical cord it looks like. So in this diagram, what we are seeing the placenta. So here it is a cotyledons, what we are seeing is, and this one is the fetus and whatever it is connection between the fetal side. This is the maternal, this is the fetal side. This one is fetal side, and from there it is connected to the fetus. So this is actually connection between or the position of the umbilical cord, the placenta, and the fetus. So how? So actually, it's in development point of view, it is the umbilical cord. It is from the primitive umbilical vein, and that expansion of amniotic cavity, which will lead to the folding, the ventral shifting of amino ectodermal junction, and the formation of primitive umbilical vein. So at best, it's just going to show that it is contains the connecting stalk containing the Allen ties and the umbilical vessels, vitelline duct and vitelline vessels, connection between intraembryonic and extraembryonic cord. So that is how it is. And this primitive umbilical cord, this expansion of amniotic cavity leads to that of elongation of umbilical cord, and it's contains yolk sac and vitelline duct connecting stalk with the remnant of elephytes, intestinal loop and inner stromal part and umbilical and vitelline vessels. Then there is a return of this intestinal lobe to abdominal cavity at third month, and this obliteration of vitelline duct and twice extraembryonic part of vitelline vessels, and this degeneration of one umbilical vein with the persistence of other veins and two umbilical arteries. What I have already explained, that is initially there are two umbilical veins and the two umbilical arteries, but afterwards one umbilical vein it gets degenerated. So this transformation of mesoderm of connecting stalk into the Morton string, whatever the mesoderm it is connected to, into the Morton string. So that is in short the concept of this. What is it? Embryonic disc with ectoderm. That this pericardium, how it is the embryo development. In short, it is explained over here. That is what we are saying villas and the stock connecting stock. What I already explained, that is how it is developed this umbilical cord. After which it gets elongated and forms the umbilical cord, and in between, over here, it is the yolk sac. This is the heart. This is the pericardial activity. On the outside, it is the amniotic cavity, and afterwards, slowly, this is connected to afterwards forms the umbilical cord. How it is initially, this is the yolk sac, this is amniotic sac, yolk sac, amniotic sac, then afterwards it develops this part develops the ectoderm, then it is neural plate that is formed, then this is the inside it is the vitelline duct which is formed, and the septum transversum, and from where it is the umbilical cord it is formed. This is in short concept of how the umbilical cord is formed. And if you see the overall structure, is that what we know that this is the placenta part of it, that is the placenta, that is villus chorion, and if whatever the structure, which is this umbilical cord, then what we are seeing, this is the fetus, then whatever this line, it is the amnion, and this is the this color, this it is the chorionic sac. So this is in short view of what is the connection of placenta, umbilical cord, and the fetus. And this is what we can say that it is the top and cut section of the tick. Take it how it looks like. So there are some abnormalities of this umbilical cord. As I have already explained, it is the lengthwise and the lengthwise it is there. But if length it is about some 50 to 60 centimeters. But if this length it can be short also and it can be long also. So that is also abnormality. So sometimes there is a problem from the lengthwise, problem from the loopwise, problem from the knotwise, problem from the content wise, and fifth one is that is related with the problem from the pathological point of view. So what I have already explained that if the length it is short, that is also a problematic situation for the fetus or for the pregnancy. And if the length is so long, that is also a problem for the fetus. Then what is, how is? So if the cord, it is umbilical cord, it is short, what it leads to? So whatever it leads to the premature, because whenever the third trimester fetus do the movement, and what it leads to, there is an early separation of placenta. That is leads to antepartum hemorrhage, that is abruptio placenta. That may be the problematic situation. The development does not take place properly. And second variety, that is called variety that is opposite to it. If the length of the umbilical cord can become short, the opposite can happen. That is, the umbilical cord becomes long also. So what will happen? It leads to. So it may sometimes encircle the neck of the fetus and may from the it from the loop. So if it is one loop, then it is one loop. If it is two, then it is two loop. When it is three, it is three loops. Or sometimes there is a due to the movement of it, the this umbilical cord form the knot around, and it is actually through knot can take place. We know that some false knots are present, but due to the length, it can lead to the true knots, and second, it can lead to the loops. And depending upon the loops, that is what we see that umbilical cord is twisted around the neck of the fetus. And depending upon the numbers, it is one loop. If it is two, then two loops. If it is three, then it is three loops. And then sometimes there is a congenital umbilical hernia that is called as a omphalocele, that is the cord contains polyps of intestine. That may be the situation. Then third variety, that is the knot point of view. That is what I already. If it is true knot, then it's but obvious there is a false knot also. And content wise, as we know that normally how what is the content of umbilical cord, that what we know is it is two arteries and the one vein, but sometimes there is some problem about the content, that is the single umbilical artery. That is also abnormality. And the next that is sometimes there is a formation of cyst which is present in the umbilical cord, and sometimes there is a problem of abnormal attachment of the cord. As we know that normally the cord should be umbilical cord should arises from the fetal surface and the central part of it. Just see in this diagram. Everywhere, so whatever the actual what we have seen, yes. In this diagram, what we are saying is this umbilical cord, it is started from the central part of it. This is the attachment. This is the normal things. But sometimes it is started from here. That is also abnormality. Or sometimes there is some filament start here like this. So it can lead to the abnormality. So that is called as battledore attachment. And if filamentous attachment of the umbilical cord, that is through membranes. That may be abnormalities. And see in this diagram what we are saying. This is the umbilical cord, no marginal insertion. What we are seeing in the previous diagram, it is here. Whatever it is, the starting from center. But if it is at the margin, then it is called as a battledore one attachment. Here it is the amnion, veins, what we are saying, this is the artery. So this is the abnormality from the attachment point of view. And this is but obvious that is the whatever this normal umbilical cord, it starts from over here. This is the point. And if it starts from this, that is called as a filamentous insertion of the umbilical cord. And this is one is the margin of the placenta. This is actually the margin of the placenta. So it should normally from where it should start? It should start from here. But actually it is starting again. If it is start from here, then it is a marginal one or battledore. Battledore we can say that. And if it is starting from the here, then this is called as a filamentous attachment of the umbilical cord. See this diagram, what we are seeing is umbilical cord. This is amnion. So what is another way we can see that the abnormalities of the problem? What is it? It is the lengthwise, long, short. Cord coiling is another there. Then pathological single umbilical artery or promesal cord, or sometimes there is a abnormalities of cord insertion. What we are seeing is the marginal and the filamentous one. Then the whatever the cord abnormalities capable of impending blood flow, torsion and the strictures, hematoma and the cyst that can be present. So what we are going to see one by one. Yes, abnormalities of the length. Normally, what is it? It is 50 to 60 centimeters. Average, it is 55. Then short cord. How much it is the short cord? If it is the less than 35 centimeter, then it is called as a short cord. And what it leads to, as already I have explained, it leads to the antepartum hemorrhage, that is the abruptio placenta, or it is called as a placental abruptio, and sometimes it can lead to the prolonged labor, or sometimes it can lead to the fetal distress. And the long cord, what is it? If it is more than 80 centimeter, is defined as a long cord. And whatever it higher occurrence of cord around the neck, that is the loop, what we call it as already I have explained. Cord around the body also is there. There is a actual knot that is called as a tooth knot or cord knot. And sometimes what happens, this if long cord is there, it prolapse from the child. So that is called as a cord prolapse, and it can lead to the compression. So that is called the cord compression. So its umbilical cord diameter was, it is lean cord. That is diameter what is a large diameter. Yes, definitely it can lead to the problem from the diameter point of view also. So if it is very small size, then it is a lean. And what it leads to, so whatever the blood supply does not take place, so it can lead to the IUGR. Now what is IUGR? It is the intrauterine growth retardation, or second synonym it is small cord deficit that may be there, or large diameter. That is, the cords are associated with macrosomia. When the weight it is more than the normal, that is macrosomia. And the growth of the IUGR, where the growth of the fetus is not up to the mark of duration of pregnancy. And what is its clinical utility of parameter? It is unclear. We don't know as such. Then umbilical cord coiling, that is cord vessel spiral through the cord, as what we know that. But there is some umbilical coiling index is the number of complete coils divided by the cord length. That is index it is used. So what is the umbilical cord coils are counted, and the total length it is counted. Same, and it is division takes place, and that is the way the umbilical coiling index is calculated. The whatever it is, they group into the as as follows. That is, UCI is as follows. That is hypocoil, normocoil, and hypercoil. From the word we can understand normocoil, that is the normal coils, that how much should be there for the normal length, and if it is less coils, then it is called hypocoil, and if it is more, then it is called as a hypercoil. Now, what is normal coil? So, if it is about 50 to 60 centimeter length, the normal it is about 10 to 98 percentile, and hypercoil, that is less than 10 percentile. That is, and for hypercoil it is more than 98 percentile. That is what is its criteria. See this in this diagram, what we are seeing. This is the normal one. This is the too much of coiling. This is of less coiling. So normal coil, hypercoil, hypocoil. But obvious, if more it is hyper, less it is hypo. This is normal coil. From the word we can understand. Then this antenatal UCI has the lower sensitivity than the measurement postpartum. Hypercoiling is linked with what is why we are saying this hypercoiling and how it looks like this in the ultrasonography. So this is how it looks like. This hypercoiling is linked with the fetal demise, that is, and the IUGR, that is intrauterine growth retardation. I have already explained. Second synonym for it is the small for dead fetus, and sometimes it leads to the intrapartum hypoxia. Hypoxia, that is blood oxygen supply does not take place properly, and abnormal UCI, that is the umbilical cord. Umbilical coiling index has been related to trisomies and the single umbilical artery. That is single umbilical artery. This one is again abnormality from the content point. Then abnormalities from the cord insertion. Usually normally the umbilical cord is inserted to the center of the fetal surface of the placenta. We know that placenta has two surfaces, fetal surface and the maternal surface. And there is various cord insertion variations are. That is marginal insertion, that is Battledore, then Perket insertion, Villamentus insertion, Vasa previa. So these are the different varieties of insertion. So just say in this diagram how it is this Perket insertion, where umbilical vessels separate from the and it is very rare one. That is what we are seeing. Rare one, and the marginal insertion where the cord insertion at the placental margin. That is what we are seeing. vessels separate from the cord substance to prepare. So what is it? Umbilical vessels separate from the cord insertion before the separation into the placenta. That is percate insertion. That is, this umbilical vessel separate from the cord insertion before their insertion into the placenta. And battled or placenta cord insertion at the placental margin, same this placental margin. And how much it is 7% at term, and the cord being full of during delivery of the placenta. That is significant. And what is there from this incidence? And filamentous insertion, that is umbilical vessels separate in the membranes at a distance from the placental margin and surrounded only by a fold of amnion. And if you see the percentage, it is about 1.1%, and it is more frequently with fins. We are going to see about it, in which condition this type of thing will happen. It's more frequently with twins, 28% of the triplets, that is what we see this type of it. This one is the actual image of battled or placenta. This one is the surface, that is the fetal surface. And just see, normal one, it will be start from over here, but this one is started from over here. So that is looks like the battle door, how the door is opening. That is normal one side door that we know it. And filamentous, just the filamentous. This type of filaments not present here, but what is it? We are seeing this filaments. So that is called as a filamentous placenta. And how it looks like this way. This is the ultrasonographic image of how it looks like. Vasa previa. What is it? It is associated with filamentous insertion when some of the fetal vessels in the membranes cross the region of the cervical os below the presenting fetal part. So it is definitely it is associated with the filamentous insertion. That is which variety? This one. This variety that is associated with vasa previa. And what happens here? Some of the fetal vessels in the membranes cross the region of cervical os and below the presenting fetal part. And how much percentage wise? Incidence wise, it is we say that 1 in 5,200 pregnancies. So very rare one. And half associated with the filamentous insertion, and the half it is associated with the marginal cord insertion and the bilobedon and sequentiata lobe placenta. That is what we know that is the abnormalities of the bilobes from the word that is two lobes are found. In that situation, we are seeing this vasa previa. You can see that. Risk factors. Why we are saying this important? The reason behind it because bilobe one, sequentiata or low-lying placenta, it leads to multifetal where it is. It is bilobe, sequentiata or low-lying placenta. In case of multifetal pregnancy, in case of pregnancy resulting from in vitro fertilization. That is what we are seeing in the fertilization, in vitro fertilization. And how can you are going to do the diagnosis of this? So the diagnosis can be done by the color Doppler examination, low sensitivity with ultrasound, then perinatal diagnosis associated with increased survival, that is about some 97 by 44, and 97 to 44. And this is antenatal diagnosis. Antenatal, that is before the delivery, associated with decreased fetal mortality compared with discovery at delivery. And what is important? The diagnosis of this condition should be done before the delivery. So that is it. Whatever it means to decrease in the fetal mortality. Then sometimes it can lead to the hemorrhage, that is the antepartum or intrapartum hemorrhage, and so that is before it. Vasa previa and the rupture fetal vessels exist. Detecting fetal blood, that is a PT test, bright stain to smear the blood on glass slides stain, the smears with bright stain and examine for nucleated RBC normally are present in cord blood, but not maternal blood. Mind it, why we are saying this? So when we collect this, so it is not present in the maternal blood, but where it is present in the cord blood. That's what we have to see. This nucleated RBC, and its the risk of low-lying placenta. It is about 80% in this. Now, this is the how the Doppler scan to detect the vasa previa. That is what we are seeing. This is the head of the fetus, and what we are seeing these are the fetal vessels. So, what I say is that fetal head, that is presenting part of it. This is the inner cervical os, and what we are seeing, these vessels are present. So, that is how it clinically vasa previa, which will be seen during Doppler scan. And how we are going to do the management. So definitely it has to be diagnosed prenatally, that is not during the delivery. That's why if you diagnose it previously, it prevents or it decreases the fetal mortality. And for that, what we have to do is, but obviously we have to think about the planned cesarean section early enough to avoid the emergency. That is not be in the emergency situation, but late enough to avoid the prematurity. And the baby requires aggressive resuscitation plus blood transfusion. So we have to think about this condition. And if intrapartum vaginal bleeding is there, that is then what is speculum, epiphytis, fetal hemoglobin is alkali resistant. And if fetal bleeding confirm immediate cesarean section, that's what we have to think about it. But important that we should diagnose it previously. That is most important. That is diagnose prenatally. Diagnose prenatally. That is most important. Then from the abnormalities from the vessel number, that is the single umbilical artery results due to the atrophy of the previously existing umbilical artery. That what I know that there are two umbilical arteries and single umbilical vein. Then it is normal, but sometimes it is single umbilical artery. And why this is single? What happens to the another artery? So what is it is due to the atrophy of the previously existing umbilical artery. And sometimes there is some four-vessel cord that is quite uncommon one, or we can say that it is very rare situation. Maybe a venous remnant. What we know that in previously, the whatever the venous part it gets degenerated, and its association with CMS is not clear why it is. But as we know that initially there are two umbilical veins and two umbilical arteries. Out of that, one umbilical vein degenerates. So that may be the remnant part of it. So, but obviously there is a four-vessel cord. That is the situation. In single umbilical artery, that is absence of one umbilical artery. And how much is the incidence? It is 0.63% in live birth and 1.92% in the perinatal deaths and 3% in the twins. And which condition the single umbilical artery association it is increased. So it is increased in the diabetes, epilepsy, PET, APH, antepartum hemorrhage, then hydrominous chromosomal abnormalities can lead to the single umbilical artery. So how we are going to see? Just see in this cross section. Here is a cross section of the umbilical cross section of the umbilical cord, in which there is only a single artery and a vein, a two-vessel umbilical artery. Such cords occur in about 1% of the birth. That's what we have to know about it. Then single umbilical artery and CMS. About 30% of all infants with only one umbilical artery have congenital anomalies. Association of CMF. So what we say that aneuploidies, tracheoesophageal fistula may be there. There may be problem for the renal development, that is renal agenesis, imperforate anus, vertebral defects. 34% are growth restricted and 17% are deliver preterm. That may be the problem of the single umbilical artery. Then sometimes there is a fused umbilical artery. What happens that this two umbilical arteries get fused. That is a very rarely umbilical artery method. It's shared and fusion movement is there and may involve the entire length or may be partial. That is towards the placental insertion site. That may be the situation. Then sometimes there is a situation. Sometimes there is a mitral anastomosis between the two umbilical arteries within 3 centimeter of placental insertion site acts as a pressure equalizing system between the two umbilical arteries, improves placental perfusion during the uterine contraction and during the compression of one of the umbilical arteries. So that is how these abnormalities can be seen. So this is just initial part of the abnormalities of the umbilical artery, that is from the lengthwise, then from the content wise that what we have seen, and from the attachment point of view.